This video will be part 2 of a series on the superior and posterior mediastinum. Part 2 will focus more on the posterior mediastinum and its contents to help us complete our three-dimensional view of the entire mediastinum. Let's first start by identifying the borders of the inferior mediastinum, because remember, the posterior mediastinum is simply a small division of the inferior mediastinum. Anteriorly, the sternum with its associated costal cartilages. Posteriorly, you have the thoracic vertebral bodies. And superiorly, we now have the transverse thoracic plane, that imaginary line that passes from the sternal angle to thoracic vertebral level 4 and 5. And then inferiorly, we still have the diaphragm. So now we'll look closer at these divisions of the inferior mediastinum. We've looked closely at the middle mediastinum and how the heart and roots of the great vessels compose that middle mediastinum as they're wrapped in the pericardium. The pericardium is what is going to divide our inferior mediastinum into anterior, middle, and posterior divisions. Now the anterior mediastinum is going to have the following borders. Anteriorly, the sternum and costal cartilage, as you can see in the image. Superiorly, that transverse thoracic plane. Posteriorly, the pericardium, of course. And then inferiorly, the diaphragm. We haven't really discussed the anterior mediastinum, and that's because it doesn't really truly have many contents. You do have some fatty and connective tissue with the associated superficial veins. Sometimes you do have the thymic tissue or remnants of the thymus descending from the superior mediastinum into the most proximal part of that anterior mediastinum. So really it's empty space with connective tissue, fat, and veins, and maybe a little bit of the thymus remnants. The middle mediastinum, of course, has the heart and roots of the great vessels, all enclosed in the pericardium. But we're going to focus more on this posterior mediastinum. The borders you can see again in this image are going to be anteriorly the pericardium, posteriorly the thoracic vertebral bodies, superiorly the transverse thoracic plane, and inferiorly the diaphragm. So we are going to need to look a little closer at these different structures in the posterior mediastinum. First, we're going to look at these first four: the esophagus, the thoracic aorta, the azygous veins, and the thoracic duct, and how they're related to one another. And then finally, we'll go through the splanchnic nerves. Let's first look at a cross-section through the inferior mediastinum. Notice that you don't see the bait relationship. You really don't even see a trachea or a patent airway. We do see heart and lungs, so we know we're in the mediastinum, but since we don't see the airway, we know we are in the inferior mediastinum because we have to be below the level of that transverse thoracic plane. Let's start by identifying the borders of this posterior mediastinum so we understand what specific area we need to focus on. Anteriorly, with the black line, you can see that we're indicating the pericardium as the anterior border. Laterally, you have the mediastinal parietal pleura, and posteriorly, the body of the thoracic vertebra. Circled here in pink is the esophagus. We've already discussed the esophagus with the superior mediastinum, and that's going to be similar for a couple of these structures because, as we talked about with the superior mediastinum, they are vertical and they're going to travel through the different divisions. But what we need to keep in mind is that the relationships change as they move through the different divisions. So the esophagus here is going to be the most anterior structure. Therefore, it's going to be most closely associated with the pericardium than any other structure in the posterior mediastinum, specifically the left atrium here. You can imagine if the left atrium was to enlarge and balloon out, it could easily compress that esophagus. That's why sometimes with left atrial enlargement, we can have difficulty swallowing or dysphagia, because the esophagus cannot expand to allow the food bolus to pass. So the patient does have some difficulty when they try to swallow. It feels like the food gets stuck. So the thoracic duct is seen here in green, and it's going to be found just posterior to the esophagus. As he ascends, he'll be collecting lymph and chyle and transmitting it back to the venous circulation. The descending thoracic aorta, circled here in red, is just to the left of the esophagus and thoracic duct. It's always going to be found just to the left of midline in the chest. Realize that it's also going to travel posterior laterally to the esophagus as it descends. The most posterior structure is always going to be the azygous system of veins. You can see the azygous vein on the right itself, just in front of the posterior border, that thoracic vertebral body. It's receiving one of its tributaries that we're going to talk about, the hemiazygous. And you'll realize after we discuss the system of veins that this is probably around thoracic vertebral level 9 for us to be able to see the hemiazygous entering the azygous. The main point to take here is that the azygous system is always going to be the most posterior structure. Let's look a little closer at each structure, starting with the esophagus. The esophagus is seen here as striated muscle as it descends through the chest. It originates in the neck and communicates with the pharynx. So it originates around cervical vertebral level 6. So when we swallow food, it'll enter our oral cavity, our pharynx, and then around CV6 pass into our esophagus. We saw that the esophagus descended posterior to the trachea and the superior mediastinum. Once we meet that transverse thoracic plane, we lose our trachea, but notice the esophagus continues to descend along the anterior surface of the vertebral bodies. It's going to descend all the way to the diaphragm to pass through the esophageal hiatus. This occurs right around thoracic vertebral level 10. Notice as the esophagus approaches the esophageal hiatus around TV10, it's slowly moving to the left and becoming more anterior to the aorta. We also discussed the aortic arch in the superior mediastinum. You can see it arching over the left main bronchus, and then right when it reaches that transverse thoracic plane, we can see it begin to descend. As it descends posterior to that main bronchus, notice it's going to descend posterior laterally to the esophagus and eventually become posterior right before they pass through the diaphragm. On the surface of the esophagus, this is going to be the vagus. You know it's the vagus because it's passing posterior to the root of the lung here, and then coming to travel along the esophagus. This is the left vagus, but notice it slowly moves anteriorly. Due to the counterclockwise rotation of the gut during development, we're going to see that the left anterior vagus slowly moves anteriorly. The right will be moving posteriorly. They'll travel on the esophagus all the way to the diaphragm to eventually pass through the esophageal hiatus, and then the left vagus will become the anterior vagal trunk, while the right vagus becomes the posterior vagal trunk. Let's look closer at the vagus nerves now. So the left and right vagus both contribute fibers to anterior and posterior esophageal plexuses. The anterior being the smaller and the posterior being the larger plexus. These plexuses are going to distribute parasympathetic fibers to the viscera in the thoracic cavity, and then continue as our anterior vagal trunks in the abdomen to provide parasympathetic fibers to the abdominal viscera. Again, remember we have that counterclockwise rotation of the gut during development that's going to move our left vagus anteriorly and our right vagus posteriorly. So the thoracic aorta begins right at TV4-5 in that transverse thoracic plane when the arch of the aorta terminates. It then descends posterior lateral to the esophagus along vertebral bodies 5 through 12 to eventually reach its aortic hiatus at TV12, where it will enter the abdomen. As it descends along this route, it's going to give off numerous branches. We're first going to talk about the somatic branches. Posterior intercostals 3 through 11 are all going to be branches from that descending thoracic aorta. So here you see the third intercostal artery. Intercostal arteries 1 and 2 typically come off the subclavian artery from the costocervical trunk. So this is the third intercostal artery, and it's going to travel on the inferior aspect of the third rib. It actually travels in a groove of the rib called the costal groove with the same numbered intercostal nerve and vein. Now, it's also going to be traveling within the third intercostal space, because remember, the intercostal space is named for the superior numbered rib. The 12th is called the subcostal artery because it's under the 12th rib. It's no longer going to be between ribs, and that's going to be inferior to the diaphragm. We also have visceral branches originating from our descending thoracic aorta. Here you see a bronchial branch. It typically supplies the left main bronchus. Sometimes it will also supply a little bit of the right main bronchus, but the right main bronchus usually receives blood supply from the right intercostals right around the 3rd and 4th level. Then you have numerous esophageal branches that you can see networking over the esophagus in this image that are going to help supply the esophagus itself. We also talked about a superior phrenic that's going to come off the descending thoracic aorta on top of the diaphragm to supply the diaphragm. Here you can actually see the inferior phrenic, which is the first branch off the abdominal aorta, as it supplies the inferior surface of the diaphragm. So let's look at the azygous system. This is a really variable system of veins, and it's going to provide collateral venous flow between the inferior vena cava in the abdomen and the superior vena cava in the chest. So it actually originates in the abdomen, ascends all the way through the thoracic cavity, and then eventually terminates in the superior vena cava. The azygous system is going to be draining the venous blood from the posterior wall of the abdomen and the thorax. And you saw in the initial cross-section we looked at that it was always going to be the most posterior structures. This view of the right chest wall allows us to look at the azygous system of veins, but specifically the azygous vein itself and the arch of the azygos. So let's discuss this portion first. The azygous vein is what's going to be responsible mainly for draining the right thoracic cavity. The visceral veins will eventually drain into the intercostal veins. Then those intercostal veins are going to drain into the azygous vein itself. Here you see the azygous vein. Again, the most posterior structure in the posterior mediastinum. You can see it ascending posterior to the esophagus in this image. You can also see here as it receives the intercostal veins in its posterior wall. And then right when it reaches the transverse thoracic plane, it begins to arch. It arches posteriorly to anteriorly over that right main bronchus. This is known as the arch of the azygos, and it originates right around the transverse thoracic plane at TV4-5. And initially it's going to be posterior to the root of the lung and then superior. You can see here how it drains into the posterior wall of the superior vena cava, eventually returning venous blood to the right atrium. Now the hemiazygous vein we can't really see in this image, but we could see it in that first cross section we looked at. And it's going to be a smaller version of the azygos on the left side essentially. It is a tributary to the azygos, and it will cross midline to dump into the azygos around TV9 usually. And it's going to be passed left to right, anterior to the vertebral column, but it will be the most posterior structure in the mediastinum when it crosses midline. This image gives us a schematic of the entire azygos system. All the viscera has been removed, as well as the remaining structures of the posterior mediastinum, so that all we can visualize is the azygos system. Recall that it was a collateral circulation between the superior vena cava and the inferior vena cava. So you're going to see that the azygos and the hemiazygos typically can have connection to the inferior vena cava, whether it's through its tributaries or directly to that inferior vena cava. The azygos itself can be seen more on the right chest wall, which we saw in the last image, and it originates when the subcostal merges with the ascending lumbar. Follow the ascending lumbar here. You can see where the 12th or subcostal vein enters here, and then you have the azygos ascending in the thoracic cavity, again in the posterior mediastinum as the most posterior structure, and receiving all the intercostal veins from the right posterior chest wall, eventually becoming the arch of the azygos as it ascends and arches over that right main bronchus to enter the posterior wall of the superior vena cava and terminate. Now let's look a little closer at the hemiazygous vein, the tributary that we mentioned crossing at TV9 to enter the azygous vein. The hemiazygous vein originates in the abdomen. Here you can see the ascending lumbar vein merging with the subcostal vein, but you also see a connection to the left renal vein, which will in turn connect it to the inferior vena cava. It ascends in the chest wall on the left side, typically collecting about 9, 10, and 11 intercostal as well as the subcostal on the left side. It doesn't usually go beyond TV9 before it crosses midline, moving from left to right behind all these structures in the posterior mediastinum to terminate in the azygous vein. So it's going to be posterior to the aorta, posterior to the thoracic duct, which is actually in this image in green, and posterior to the esophagus. Now there is also an accessory hemiazygous. I mentioned this only for completeness, but it's going to be draining the more superior intercostal veins on the left side, usually about 5 through 8. It'll cross midline around thoracic vertebral level 8, and typically does also empty into the azygous vein. So let's look closer at the structures we just discussed and make sure you can identify them in the CT scan of the chest with contrast. The esophagus is seen here. You can't see the lumen very well because it does easily collapse. But notice it's just behind the heart, but in the most anterior structure of the posterior mediastinum. The aorta is very easy to find, and commonly what I use first to find most of the other structures because it does get lit up with contrast here, and it's always just to the left of midline traveling on that vertebral body. So then we have our azygous here traveling along the vertebral body, which is going to be one of our most posterior structures, and the hemiazygous is even labeled here, so that's going to tell us that we're below thoracic vertebral level 9 most likely. And you can appreciate how the hemiazygous would pass posterior to the aorta to dump into the azygous vein. So our thoracic duct isn't something we can typically see on a CT scan unless it's dilated because of pathology, but it would be located here in the middle of all of these structures with that green stars indicated. So what is the thoracic duct? It's a structure that's going to be draining lymph and chyle from below the diaphragm and above the diaphragm, but only on the left side. So the head, neck, chest, and arm on the left side, the abdominal area, and the lower extremities are all draining into the thoracic duct. The thoracic duct also originates in the abdomen. It originates from a dilated sac we call the cisterna chyli. The cisterna chyli originates when all the intestinal and lumbar lymphatic trunks merge together to form this big dilated collection of lymphatic vessels. That is going to actually be found just behind the aorta around lumbar vertebral level 1 or 2. And then ascending from the cisterna chyli is where the thoracic duct originates. It ascends through the aortic hiatus at TV12, sandwiched between the aorta and the azygous system. It will continue to ascend through the thoracic cavity to eventually terminate at a venous angle. That venous angle is going to be where the internal jugular and subclavian veins came together on the left side to form the left brachiocephalic vein. So right at the angle formed where those two veins are merging. We'll look closer at that in the next image. Since it does travel on the anterior aspects of the vertebral bodies and so intimate, it can easily be damaged. It's a very thin-walled structure similar to a vein. So if there was a fracture of the vertebral body, it could cause trauma to the thoracic duct. Lymph could leak into the thoracic cavity. Lymph is a white milky substance. So instead of a hemothorax where blood would be located, we now have a white milky substance in the chest, and we call that a chylothorax. Just as dangerous, however, as a hemothorax, and something that has to be repaired. So let's look closer at the thoracic duct and its relationship to the other structures we've discussed. You can see it labeled here as TD and indicated green in the image. Inferiorly, you can see where it's ascending through the diaphragm at the aortic hiatus between the azygous and the aorta, and it continues to ascend on those vertebral bodies, crossing midline right at the transverse thoracic plane, moving from the right to the left, continue to ascend through that superior mediastinum, and then eventually wrapping posteriorly around the internal jugular to terminate in that left venous angle. So here you see the angle we talked about, where the left subclavian and left internal jugular merge to form the left brachiocephalic. It actually does create an angle, indicated in the image here, and you can see how the thoracic duct typically comes somewhere in this area of that angle. The left supraclavicular node is located in this area. You've heard us mention Virchow's node, V-I-R-C-H-O-W-S, and since 2/3 of the body's length is being transmitted through this node and eventually into this venous angle, it is a very common site of metastatic cancer. Specifically, it's very commonly associated with gastric cancer. So painless node enlargement, or Virchow's node, is a classic association with gastric cancer. That's because gastric or stomach cancer has very few symptoms and can typically metastasize before it's identified. And now you understand why it's more typically going to be on the left, because that's where the majority of the lymph from our body is going to flow. Now, we did say that the right chest, arm, head, and neck do not go to the left venous angle. Those instead go to the right venous angle via the right lymphatic duct. You can follow the right lymphatic duct as it ascends and appreciate that it takes a very similar course as it wraps posteriorly around the internal jugular on the right side to terminate in that right venous angle. So again, that's going to be draining the right head, neck, arm, and chest. Finally, we're going to look at the splanchnic nerves. Splanchnic nerves are preganglionic sympathetic fibers that are going to eventually continue to course into abdominal ganglia where they're going to synapse. That's because they pass through the sympathetic chain without synapsing. And unlike most sympathetic nerves, have very long preganglionic fibers. They synapse on different ganglia located within the abdomen, very close to the aorta actually. The greater splanchnic nerve is the largest, receiving the most fibers, and it's going to be the one that we can actually view in our dissection, because it's receiving fibers from T5, 6, 7, 8, and 9. Once it reaches the abdomen, it will synapse on the postganglionic cell body and send postganglionic sympathetic fibers along the vessels to reach the different viscera of the abdomen and supply them with sympathetic innervation. The lesser splanchnic receives T10 and T11 fibers. This is going to be a little more difficult to see in the dissection because the diaphragm typically obscures its view, but know that it's there, which fibers contribute to it, and then it will eventually reach the abdomen where it will synapse at the aortico-renal ganglion, which is going to be on the aorta near where the renal arteries originate, as its name implies. And that postganglionic cell body will send postganglionic sympathetic fibers along vessels to provide sympathetic innervation to abdominal viscera. The smaller is the least splanchnic nerve, receiving only fibers from T12. Again, not one that we'll likely be able to visualize, but know that contributing fibers are from T12, and that it will eventually synapse on the renal ganglia to send postganglionic sympathetic fibers to the abdominal viscera along vessels. Let's look a little closer at the greater splanchnic nerve because it's one that we will actually be able to identify in our patient. So let's count some ribs. 1, 2, 3, 4, 5. So you can see this is 5, 6, 7, 8, 9 is obscured by the diaphragm, but I promise 9 also contributes to the greater splanchnic. So those fibers are going to move anteriorly from the sympathetic chain to contribute eventually to this greater splanchnic nerve. Notice as the greater splanchnic nerve continues to gain fibers, it moves anteriorly towards the azygos to have a posterior lateral relationship with that azygos. To visualize this, you're going to have to remove the costal parietal pleura, as they've also done in this image. On the left side, instead of being posterior lateral to the azygos, it's now going to be posterior lateral to the hemiazygos vein and the descending thoracic aorta. And again, you can see fibers from 5, 6, 7, and 8, eventually 9 as well, contribute to that greater splanchnic, which is going to be anterior to the sympathetic chain. Again, removing that costal parietal pleura is how you're going to visualize these structures. This concludes part 2 of the superior and posterior mediastinum series, and you should now have a better understanding of the mediastinum as a whole and the anatomical relationships of the various structures as they pass through the different divisions.